Right? So can I start? Hi, good evening, everyone. I'm Dr. Pooja Uniyal, a senior consultant IVF specialist at Medicover Fertility, Rohini. So today we are going to discuss a very important topic about the two treatment options which are having for couple with infertility. That's IUI and IVF. So who exactly do need treatment for infertility? Any couple who have been trying to conceive since 12 months of unprotected intercourse and they're not able to conceive, that couple is labeled as infertile. And as a treatment option, one of the treatment option is IUI and second treatment option is IVF. And it's already always individualized. Which patient should go for IUI, which patient should go for IVF. So first we'll discuss about IUI. What exactly, how IUI is a little better than IVF or not better than IVF, we'll discuss about IUI. First, IUI is less invasive as compared to IVF. In IUI, we usually put the washed sperm directly into the uterus of the woman during the fertile period. And it can be done as a part of the natural cycle, or we can combine it with clomiphene citrate or letrose. We can do an ovulation induction, and then we can do an IUI. So IUI, in which we only wash the patient's husband's sperm, we wash it, it increases in motility, its count, and we then put it inside the uterus. That's only what we are doing. We are just getting the sperm closer to the eggs. So definitely the chance of conception increases. And we usually do it in patient with anovulatory dysfunction or unexplained infertility. And we usually combine ovulation induction with this. Ovulation induction, in which we increases the number of eggs per cycle. Ideally, only one egg per cycle is usually developed in a patient. But when we do ovulation induction, it can lead to multiple pregnancy as multiple eggs can develop. And it usually increases the chance of IUI also. So we do ovulation induction by either gonadotropin injection or basically by drugs which are letrose and clomiphene. Apart from that, in IUI, the semen don't need to swim to reach the tubes where the egg is waiting for fertilization. So it decreases the distance between the sperm and the egg. That's also a effect to increase fertility in IUI. Apart from that, patient with unexplained infertility, patient with ovulatory dysfunction, they are usually which we do IUI for, but they can also help in patients who are not able to have timely intercourse because of their busy work schedule or their travel duties and everything, or if the couple is having sexual dysfunction, they're not able to have a proper intercourse. And these patient IUI does wonder. But what should be known is that in order to increase the number of eggs, we do give hormonal medications, which I already told, an injection, which can lead to multiple pregnancy also. So the overall success of IUI, if done in a natural cycle, is almost 10 to 15%, not more than that. And in a case in which we are giving ovulation induction or gonadotropin, in that case, it's usually around 20 to 25%, not more than that, because the fertilization and the implantation are happening inside the body. We don't have a control over it. What we do is we just process the sperm, give them a better motility, they get a better count, and just put it inside the uterus and just wish that they fertilize. And very important part is that IUI can only be done if the patient is having a patent fallopian tube or no tubal defect. If the patient is having a tubal defect, then the couple should directly switch off to IVF. What exactly we do in IVF? See, IUI can be a good starting point for a couple of infertility issue involving ovulation and unexplained infertility or any sexual dysfunction, but it might not be the most suitable fertility approach. IVF definitely has a better result than IUI, and IVF is to be done in the following condition. First, if there is severe male infertility. If the count is quite less, it's less than 10 million per ml, IUI is usually not preferred. If the patient comes to us with 2 million, 3 million, 4 million sperm count, so we usually go for IVF, and even in IVF, we do go for ICSI. ICSI is intracytoplasmic sperm injection, in which we take one egg under the microscope and insert a good healthy spermatozoa inside the egg which has been received. So if patient is coming to us with severe male infertility with a history of they have been trying for more than 1 year, and severe male infertility which is we initially first give them drugs, so if they can increase. But if the count is the same, then what we do, we go for ICSI, for IVF directly. IUI has no role in that. Very less success done. Second, if there's blocked fallopian tube. The first IVF baby was done because of this indication. Blocked fallopian tube, bilateral fallopian tube, is the most common indication for IVF, and the result definitely is good if the tubes are only blocked and rest everything is fine. Then there can be lack of success of IUI. If we try for IUI for unexplained or any other reason, and patient has already been done 4 or 5 cycles of IUI, then it's better to get the patient into IVF. Otherwise, when we get the patient for IVF, the egg reserve have already decreased because of so much trying and so much ovulation induction and IUI, that we don't get enough eggs that we need for IVF. So you should be very specific that after this much attempt, after this much IUI, we have to switch off to IVF. Otherwise, definitely, if we'll get less eggs, less number of eggs, less number of embryos, so the result will also decrease. And by the time the patient comes to us, we don't have any good number of eggs why we can give the patient, the couple, a good eukaryote embryo. Then there have been concern of certain genetic disorder, passing of some genetic disorder. There are many couples who actually come, they have a history of genetic disorder in their family, or genetic disorder in their previous child, or in both of one of the couple, they can have the genetic problem. So we can do pre-genetic testing, which is a very important part of IVF. And in pre-genetic testing, we can know that which embryos are having that genetic condition and that are not transferred, and which embryos are safe and not having that genetic condition. And PGD is a wonderful technique which are used in IVF. And in IVF only, we can transfer a good genetically safe euploid embryo, and the patient can be free, the baby can be free of any genetic condition which are there in the mother or any family history. PGD is very advanced scientific procedure, and we usually perform it before IVF, before embryo transfer. We take the biopsy of the embryo, day 5 embryo formed, and we see if have the genetic condition. And it usually we usually do it if the patient is more than 38 years of age, because definitely the risk of Down syndrome increases. And if the patient is going with their own eggs, we take it if there's a history of recurrent miscarriages, or there's history of any genetic disorder in the sibling or the parents themselves. Apart from that, the success of IVF is around 50 to 55%. Success is never guaranteed in IVF. What we do is we just implant, we just transfer the embryo transfer is we make the embryo outside and we transfer the embryo inside the uterus, but it has to implant itself. We give all the post embryo transfer medication and tell the patient to rest and follow all the precautions which she can do. And the success rate is around 50 to 55%, which can be increased to 60 to 65% if the patient age is less than 35 years of age. There's no gross abnormality of the uterus, the endometrial lining is good when we transfer the baby. And after the embryo transfer, the patient take rest and there's no fever or anything the patient is experiencing. Definitely the results increases in IVF also. So every patient and every situation is different. If you should meet your fertility specialist and review your history and get the recommendation they are telling you to for IUI and IVF. But every patient is different, they have to be treated accordingly. And infertility is very common nowadays, so whenever a patient is trying to conceive and they are not able to conceive, they should definitely visit their specialist and should review themselves. So that's all for today. If there's any other question regarding IUI or IVF, or if you are having any doubt, you can please let me know. So in our setup, we are situated Medicover Fertility in Rohini. The success of IUI around 20 to 25%, and IVF is around 55 to 60%. And there are many other things, many other medication which can actually increases your success. You can have some multivitamins, and even it depends on your husband semen, how the semen parameters, your AMH, your egg. Even in patient which come with very less AMH, ideally 0.1 or 0.2, then we do, and we can't see any AFC count, antifollicle count, we go for donor IVF, which is not we can't do any IUI with it. So even this is a very important thing in a patient with less AMH, decreased AMH, diminished ovarian reserve. It usually happens most post 40 years, but it can happen before also when there is ovarian failure. If the patient comes to us with that, then IUI is not that significantly increase the chance, but definitely IVF with OD, donor cycle, can increase the chance of pregnancy, and the patient can get even if she gets menopause. So first question is, what's the difference between IUI and IVF? That I've already explained. IUI is less invasive. IVF in IVF we usually give injection gonadotropin from second day of the cycle till 14th day. We take out the eggs, which is done ovum pickup, which is done transvaginally. Intravaginally we put a needle and we just we take out the eggs, we suction out the eggs, and then the embryos are formed, and then we transfer the embryo as a procedure, which is embryo transfer, which is very painless procedure in which a catheter is put and we transfer the embryo inside the uterus. So that's a different. IVF, we are making the baby and we are transferring the baby inside the uterus. So that's why the result is more, the success is more. IUI is less. Definitely, there is the possibility of multiple pregnancy. In IVF, the possibility of multiple pregnancy is around 30 to 40%, but in IUI, it's around 10 to 25%. But definitely, I have seen many cases, many patients who has undergone IUI, and I just delivered the twins yesterday. The twins were delivered, male and female baby, and they delivered after an IUI. In IUI, if we give clomiphene and there are more number of eggs which are formed in IUI, definitely you can have a multiple pregnancy both in IUI and IVF. What is the cost of IUI? Cost of IUI is in our center is around 15,000 to 25,000, depend upon your semen is taken or donor semen is taken, and it's different according. But its minimum is around 10,000. The cost of IUI. Medicover Fertility. Yes, Medicover Fertility is in Hyderabad also. Definitely, it's in Hyderabad also. So yes, definitely multiple pregnancy can happen in IUI, it can happen in IVF, but definitely IVF is a better success rate. So if the patient is trying to conceive since a long time and having failure, then definitely IVF is a good option. But definitely no options in 100% guaranteed. We can just try, we give our best. We want all our patients which are coming to us to get pregnant. That's the only thing a doctor wants, and definitely. Thank you so much. Thank you so much. So if there are any other questions in which you should go for IUI, I will. Is ovulation induction and IUI same? No, ovulation induction is completely different. IUI is completely different. In ovulation induction, see, if the patient come to us initially, so we can give ovulation induction is giving some tablets, oral tablets to the patient so that it can make more number of eggs. So we can tell the patient to have ovulation induction and timed intercourse also if the patient can do. Ovulation induction, we just make the more number of eggs. In patient who was having an ovulatory cycle, who are having PCOD, in which they're not able to ovulate, we usually give for 5 days of ovulation induction, which can be through, I told you, letrozole or clomiphene with gonadotropin in form of HMG or FSH. And then when the egg, we see follicular monitoring from the day 10 or day 11 of the cycle, we see how the eggs are forming. When the egg will rupture, the patient can have timed intercourse. So it's only ovulation induction. In IUI can be done in a natural cycle also, where you don't need ovulation induction if the patient is ovulating naturally. If naturally the patient is forming egg and the egg is rupturing on day 14, then we can do an IUI in a natural cycle. But usually when we do an IUI, we try that, let's make ovulation induction, let's give her some tablets if there's anovulate, if the patient is PCOD or she's not able to ovulate. So we do give her ovulation induction in form of some tablets, and then we do IUI. It increases the chance. I told you, in natural cycle IUI, it's usually around 10%. In ovulation induction with IUI, it's around 20 to 25%. So we prefer to do ovulation induction, especially with gonadotropins, injections, or. But you can also do plain ovulation induction without an IUI and try with that also. But the success is a little less as compared to ovulation induction with IUI. So the success rate of IUI is around 20 to 25%. How many IUI cycles? Usually 3 to 4, not more than 4. In papers or in studies, we see it, and we can do 6 cycles, but it's better that if 3 or 4 cycles of IUI are failed, you should go for further treatment. You should go for IVF definitely. Thank you. What is the latest IVF technology in research? So in IVF, we usually do ICSI. ICSI is a newer technique which is intracytoplasmic sperm injection. In conventional IVF, we usually take all the ovum, and we keep the sperms in the test tube, and dish and we wait for them to fertilize themselves. And in ICSI, we usually take one ovum and one sperm and fertilizes in the microscope, micro manipulator with our own eyes. So definitely for male factor or unexplained also we have ICSI, which is recently. Apart from that, there are many other techniques in IVF which can help to increase the result of IVF, which are embryo glue or laser hatching. We usually do, and patient with if they have thick zona, they have day 3 embryo, they have B grade, C grade embryo, and the embryologist suggests to do a laser hatching. We do hatch the embryos with laser. And secondly, embryo glue, which have a success. Well, embryo glue is beneficial to the patient. It usually helps the embryos to get attached. So there are many things which your IVF specialist can tell you that these techniques we can help to improve the rate of IVF. Thank you. Okay, thank you so much, everyone. I hope this was a little informative for you guys. And if any other query related to IVF, IUI, or any fertility treatments, please do let us know. Thank you so much.